sovereign motherland. Our flag shall be a symbol that truth and justice reigns. Our battle honored, and this we count as gain. To hand unto our children a banner without stain. O God of all creation, grant this our one request. Help us to with peace and plenty. Nigeria may be blessed.
The University of Nigeria song.
University of Nigeria, my alma mater.
Hail and rejoice for the sake of truth. When young men and women do seek for knowledge. Hail and rejoice for the sake of knowledge.
Where the nation's potentials do brood in the nest.
Hail and rejoice for her noble ideals. University par excellence, our dreams come true. Hail and rejoice for the giant awaits. My alma mater, my alma mater. Noble are thy looks and thy ideals, and great art thou in science and in arts. In all the realms of learning thou art all sublime.
University of Nigeria, my alma mater.
Hail and rejoice for her lofty plans. On soft green hill. Hail and rejoice for her beauty's sake.
University of our glory, the pride of our land.
Hail and rejoice for her light will shine. University par excellence, our dreams come true. Hail and rejoice for the giant awaits. My alma mater, my alma mater. Noble are thy looks and thy ideals, and great art thou in science and in arts. In all the realms of learning thou art all sublime. My alma mater, my alma mater. Noble are thy looks and thy ideals, and great art thou in science and in arts. In all the realms of learning thou art all sublime.
Noble are thy looks and thou ideals. In science and in arts, in all the realms of learning, the University of Nigeria is all sublime. While we're still standing, can we please take "To God Be the Glory" first stanza?
To God be the glory, great things he has done. So loved he the world that he gave us his Son, who yielded his life and atonement for sin, and opened the life gate that all may go in. Let the earth hear his voice. Praise the Lord, praise the Lord. Let the people rejoice. Oh, come to the Father through Jesus the Son, and give him the glory. Great things he has done.
Amen. Can we please be seated? Council members of the University of Nigeria present, principal officers present, distinguished academics and non-academics, members of the fourth estate of the realm, my lords spiritual and temporal, members of the press, ladies and gentlemen, lions and lionesses. It is my utmost pleasure to welcome you to yet another discourse, yet another academic discourse of the University of Nigeria. Today is the 242nd inaugural lecture in the series of inaugural lecture of this great institution. But before we dive into all that, permit me to make some formal introduction. As always, representing the Vice Chancellor of this great institution and acting in his own right as the Deputy Vice Chancellor of this great campus, ladies and gentlemen, can we please put our hands together for Professor J.U.J. Onwumere. Ladies and gentlemen, we have a council member in our midst this morning, Professor Ike Onyeshi. Please put your hands together for our employer. Deputy Provost, College of Medicine, Professor C.C. Onyedum. Please, can we appreciate him? Venerable Professor Samuel Uwezuoke, HOD Pediatrics. Please, can we appreciate him? The Dean, Faculty of Clinicals, is being represented here by the Dean. I can't see this writing clearly, but please, can we put our hands together for the Dean, Faculty of Clinical Sciences, Professor A.O. Amucheo. I hope I pronounced that correctly. Please appreciate him. There is no inaugural lecture without past inaugural lecturers. Ladies and gentlemen, as I reel out their names, please put your hands together for them. Past inaugural lecturer, Professor Agozie Ubese, can we please appreciate him? Professor Becky Tagbo, please put your hands together for them. Professor Ngozi Njeze. Are we tired? Professor Felix Chukwuneke. Professor J.C. Eze, the Oracle. Professor Linda Oge Okoye. Professor Emmanuel Ubikili. Professor Adeze C. Ayuk, Professor B.S.C. Uzochukwu, Emeritus Professor Basil Ezanolwe, Professor Hyginus Ezegwe, the Provost College of Medicine, Professor Petra O. Namani, Professor Josephat Chinawa, Professor Mrs. Chika Onwa-Sigwe, Venerable Emeritus Professor Ernest Onwa-Sigwe, is also or was also the former Provost College of Medicine. Can we please put our hands together for Professor Agozie Ubesi? And to every other past inaugural lecturer present here, that your names are not on this list, please put your hands together for them. We appreciate all of you. You're well recognized. Ladies and gentlemen, they say that besides every successful man, there is a woman, right? An equally successful woman. Today, I'd like to say, besides every great woman, there is also a great man, spreading out his wings and allowing the woman to soar. Please, can we put our hands together for the husband of the inaugural lecturer, Engineer Fabian C. Eze. When you see a man who's not scared of the wife making it in life, you will know. You see how simple this man looks. Please put your hands together for him again. And now for the reason why we're gathered, the 242nd inaugural lecturer. Ladies and gentlemen, if your hands are not too busy, please put them together for Professor Joy Nkiru Eze. Professor Joy will be taking us on a topic that says Pediatric Respiratory Care in Nigeria, pulling down the mountain and building the ladder. And I'm sure that it will be a great one. All right, to our distinguished guests who are here, especially the men on the red cap, our chiefs over there, please get their names or get the name of the leader of that team. We'd like to recognize them specially. And everyone who is here will say welcome. Please put your hands together for yourselves. Without you, this event would not be wonderful. I'd like to recognize, in no particular order, some distinguished guests in our midst. The CMD National Orthopedic Hospital, Professor Emmanuel. Can we please put our hands together for Professor Emmanuel I? You know, doctors have a very wonderful handwriting. It's almost as if they are giving prescription with this writing. So pardon me if I don't pronounce your names correctly. It is because of your handwriting. Please, can we put our hands together for CMD Psychiatric Hospital, Dr. Ngozi Unagu. Give us a wave, Dr. Ngozi. Thank you. The CMD, Alex Ekweme Federal University Teaching Hospital, Professor Robinson Ono. Prof, give us a wave. You're welcome. Chancellor Maduka University, Dr. Samuel Onishi, I guess. Please, can we appreciate him? He's also the MD of Peace Mass Transit. We have in our midst Igwe George Asadu, representative of Igwe of Ihe-Owerri. Please, can we put our hands together for Igwe? We also have Igwe Linus Atugu. Forgive me, sir, but put your hands together for Igwe. Very Reverend Father Dr. Uchenna Baynard Ugweze. Can we please put our hands together for him? Honorable Justice I can't get that name here. But can we please put our hands together for Professor Eugene Weke? Please put your hands together for them. And we'll recognize our guests as the names come forward. Ladies and gentlemen, without wasting much of your time, please can we put our hands together as I hand the microphone over to the chairman of this occasion, the Vice Chancellor, for the chairman's opening remark. And when I come back, I will amend the blunder I just made. Please put your hands together for him.
Good afternoon, ladies and gentlemen. Member of Council here present, Professor Ike Onishi. In no particular order, the Provost, College of Medicine, the Deputy Provost, College of Medicine, my friend, Professor Onodugo, CMD, and all others here present. I must recognize Dr. Onishi, the Chancellor of Madoka University, and the Chairman of Peace Mass Transport. I hope he's here. I heard his name. He is a friend. I know I delivered their Founders Day lecture, the first Founders Day lecture. So on behalf of all of us, my distinguished colleagues, past inaugural lecturers, past heads of departments, deans, professors, colleagues, people from different CMDs from different institutions. Today's lecture is titled Pediatric Respiratory Care in Nigeria, Pulling Down the Mountain and Building the Ladder. It's a very interesting topic. All of us love children, so we are interested in this lecture in many ways. Like I've always said here, an inaugural lecture is where a masquerade comes and dances to the public and shows us those things we should look at or when we are trying to assess him or her, to assess his contributions to the academia, his contributions to knowledge in general, and to society. So today, Professor Joy Nkiru Eze is the masquerade. And we are expecting to have a very, very exciting lecture. I won't take your time because we have scheduled time for this activity. So on behalf of my boss, the Vice Chancellor of University of Nigeria, Professor Simon Uchenna Otoanya, I declare this inaugural lecture open. Thank you.
Can we please jam our hands together like we just had the Vice Chancellor declare the event open? Today, if you notice, the Chairman Senate Ceremonials is not here, but he's ably represented today by the Secretary Senate Ceremonials, a Deputy Registrar, who is also a Deputy Registrar Administrative Unit. Please put your hands together for Mr. Obinna Onwobia. I'd like to quickly recognize the family members of the inaugural lecturer. We have Nemuroha Antonia Ozuko, mother. Mommy, you're welcome. Give her a round of applause. Thank you, Mommy. You're shining elegantly. You're welcome. No. We have Professor MVC Ozuko Esquire, immediate elder brother of the inaugural lecturer. Prof, you're welcome. No. Reverend Sister Mary Kene Ozuko, also an elder sister to the inaugural lecturer. Sister, you're welcome. Can you please give us a wave? Very beautiful. You're welcome. And I like the way you're smiling. We also have Mr. Evaristus Ovoga, brother-in-law. Please put your hands together for him. Reverend Sister Mary Audrey. Please, can we put our hands together for Reverend Sister Mary Audrey? Sister, you're welcome. Mr. Chika Ozuko, younger brother, Mr. Chika, give us a wave if you're in the hall. Oh, you're very welcome. Why are you over there? We'd like to see you in front. Okay, no problem. We understand. Please appreciate him. Mr. Obinna Eze, brother-in-law, please give us a wave if you're in the hall. Thank you. Thank you for coming. Mrs. Ngozi Obinna Eze, younger sister, give us a wave. Can we please appreciate them? Engineer Pascal Eze, son. Engineer, where are you? You're welcome. Miss Chidiogo Eze, daughter. Please give us a wave, Chidiogo. You're welcome. Kenechuku Eze, son. Give us a wave, Kene. You're welcome. Kene, are you shy? Please don't be. Clap for Kenechuku, please. And then we have Ifunaya Eze. Please, can we appreciate her? We have Sister Mary Amanda. Can we please appreciate her? She's a friend of the family. And Sister Maria Audrey, I think I've recognized her before. Can we please appreciate them very specially? I'd like to also want to recognize the CMD UNTH, Professor Obinna Onodugu. Can we please put our hands together for the CMD, please? You're welcome, sir. We also want to recognize Professor Ibe BC. Please appreciate Professor Ibe. Professor A.O. Amuchazi. Amuchazi, please appreciate her very specially. Professor Ike Funa A. He is the President National Postgraduate Medical College. Please, can we appreciate him very specially? And also, I'd like to recognize Professor Becky Tagbo. Please put your hands together for her. She's a chairman of the World Health Organization, pioneer chairman of the World Health Organization, and director of the Institute of Molecular Medicine and Infectious Diseases. Please put your hands together for Professor Becky Tagbo. Put your hands together for her, please. Next on our agenda, we'd like to call on the citation reader for this inaugural lecture. Please put your hands together, if they are not too busy, for Professor Amuchazi. If you clap better, she will walk faster. Keep clapping until she handles the microphone. Clap for her, don't be tired. You're welcome, Prof.
The Vice Chancellor, presented by the Deputy Vice Chancellor, University of Nigeria New Campus, Professor Mumere, Provost, Deputy Provost, all past inaugural lecturers, distinguished ladies and gentlemen, it is my singular pleasure and honor on behalf of the Dean of the Faculty of Clinical Sciences, Professor Christopher Bismarck Eke, who is unavoidably absent today because of an assignment by the Medical and Dental Council, to present the citation of Professor Joy Nkiru Eze. Professor Joy Eze is a professor of pediatrics and an honorary consultant pediatric pulmonologist in the Department of Pediatrics, College of Medicine, University of Nigeria, as well as University of Nigeria Teaching Hospital. She was born on the eve of Easter Sunday on the 1st day of April, 1972. Her father was so proud, even at her birth, that his heart was overflowing with pride for the brilliance he could detect in her daughter, in a newborn. And she didn't prove the father wrong. In his excitement, he took her to school early. And as the days were, you have to put your hand over your head and touch your left ear with your right hand. Okwero, so far, say I'm banana. Papi asemba, na nwa mageja akwụkwọ na nwa ma akwụkwọ too much. He now took her to the kindergarten class run by the Jehovah's Witness so that she can start school. So that star in her will shine. She was there. And when school is over, her immediate elder brother, Professor March ebe Victor Ozioko, I call him Victor, will come and pick her from school and take her home. Shortly after, her hand now grew and touched the other ear. So she could now enter the primary school her father decided her to enter. She joined there, and she was excelling. From there, she went on to the secondary school at the Community Girls Secondary School, CNU, where by the hand of God, she was tutored by Dame Edna Ndili, the wife of the former Vice Chancellor of the Great Citadel of Learning, University of Nigeria, Nsukka. And she tutored her so well that Joy emerged as one of the top 3 science students in her class. After that, she gained admission into the University of Nigeria, Nsukka, the Great Citadel of Learning, to study medicine in 1991 and 1992. This admission had been powered by a desire to heal people, to prevent suffering from among people, and to improve the quality of life of people placed under her care. Her guardian, Professor Fab Honor, may God rest his soul, also played a key role in her academic journey in the university. Joy graduated in 1999. Remember, it's supposed to be a 6-year course, but because of ASU strike, of which you were also ASU, she had extra 2 years in university. So she now graduated in 1999. She had her housemanship at the University of Nigeria Teaching Hospital and went on to undertake the National Youth Service at Umuabai Health Center at Oyibo local government area in Rivers State. Then she was the only doctor providing healthcare services to both adults and children from 5 communities around that center. She left after university at the youth service to come back to do her residency training in pediatrics between 2003 and 2010. While embarking on this residency training, she also had her children. So she was combining her training with her family life and childbearing. We thank God for his mercies to her. She was inducted as a fellow of the West African College of Physicians, Faculty of Pediatrics, in 2010. After that, she moved to Port Harcourt and practiced in a private hospital until 2012, when she was appointed a hospital consultant at the University of Nigeria Teaching Hospital. After that, she moved her services to the College of Medicine, Faculty of Clinical Sciences, and was rescheduled as an honorary consultant in the university. She rose through the ranks to become a professor in the year 2022. She also obtained a certificate and MPhil degree in pediatric pulmonology in the University of Cape Town and Red Cross War Memorial Children's Hospital, South Africa, with full scholarship from the African Pediatric Fellowship Program and attestation of her excellence and hot brain. She is an examiner for both the membership and fellowship levels of examination for the West African College of Physicians, Faculty of Pediatrics, and has supervised 6 postgraduate dissertations for the award of fellowship in both the National Postgraduate Medical College of Nigeria and the West African College of Physicians, Faculty of Pediatrics. Joy is an astute writer. She has published over 50 articles in both national and international peer-reviewed high-impact journals. Her research works are in the area of air pollution, exposure to air pollution, lung health, air quality measurements, lung function measurements, including spirometry, childhood respiratory disease, allergy, pneumonia, primary ciliary dyskinesia. Should I continue? She has facilitated ongoing PCD diagnostic research in South African children and adults at the Red Cross War Memorial Hospital, Cape Town, in collaboration with the team at the University of Munster, Germany. Some of our works have earned many national and international recognitions and awards, including but not limited to the American Thoracic Society for Best in Show Award 2019, ATS Fellow 2023, International Society of Pediatric Respiratory Diseases Young Investor Award in 2024, and most recently, the 2026 ATS Philip Hopewell Global Respiratory Research Health Award. Joy was among the 2025 pioneer graduates of the ATS MECO African Woman Leadership Program. She's a giant in our midst. She serves as a reviewer to many national and international high-impact journals. She has also held some administrative positions. She's the immediate past chairman, Medical Advisory Committee, and Director of Clinical Services and Training in the University of Nigeria Teaching Hospital. And that's why CMD had to come and be here, sitting in front, not at the back. She was also the Vice Chairman of the Medical and Dental Consultants Association, UNTH chapter, and also the Vice President, past President of the MDCAN Cooperative Society. You can see she's an all-rounder, honest, hardworking, and dedicated. She's also a member of the College of Medicine Screening Committee and has also chaired several committees in UNTH. Joy has advanced lung health beyond Nigeria. She has built research collaborative network. She has formulated and advanced policies and is shaping respiratory practice in both local, regional, and global contexts. She's a member of the Nigerian Thoracic Society, an executive of the Pan-African Thoracic Society, and a fellow of the American Thoracic Society. She served in the Pediatric Association of Nigeria Steering Committee for the Control of Community-Acquired Pneumonia and coordinated the Southeast Committee that contributed to the development of the current Community-Acquired Pneumonia Treatment Guideline in Nigeria. She's indeed a great woman. She has also anchored the World Pneumonia Day programs from 2020 to 2023. The list goes on and on. But ladies and gentlemen, not a spare time, may I present to you Joy Eze, a loving wife, supportive wife with an excellent husband, powerful children, and our current inaugural lecturer. Great lions and lionesses, Professor Mrs. Joy Nkiru Eze.
Can we please put our hands together to make welcome Professor Joy Nkiru Eze.
The Vice Chancellor of this great institution, Professor Simon Uchenna Otuanya, who has given the permission and approval for me to stand here this afternoon to deliver this lecture. The Deputy Vice Chancellor, Administration, the Deputy Vice Chancellor of the University of Nigeria, Enugu Campus, Professor J.U.J. Onwumere, who is representing the Vice Chancellor and as well here in his own capacity. The Deputy Vice Chancellor Academics, Provost College of Medicine, Professor Hyginus Ezegui, my Provost, I greet you. The Deputy Provost College of Medicine, Professor Kajetan Onyedum, I greet you, sir. The Provost of the Postgraduate School, Professor Obinna Obi Okoye, I greet you. Other principal officers of the University of Nigeria, deans and past deans of the university, the representative of the Dean of Faculty of Clinical Sciences, Professor Ada Amuchazi. The other deans here present, Dean Basic Clinical Sciences, Dean Basic Medical Sciences, the Dean Faculty of Dentistry, and other deans here, directors of institutes and centers, heads of departments, my own head of department, ably represented by Professor O.C. Ezenwosu, distinguished emeritus professors and other professors. Emeritus Professor Onwasigwe, my employer, past inaugural lecturers, heads of administrative units, distinguished academics and administrators, my Lord spiritual and temporal, the religious, Reverend sisters who are representing my sister, who is joining online. She's in the United States. Traditional rulers, the Igwe, my own Igwe, and the Igwe Omekanaya. Ikpere m nọkwa n'ala. Igwe Chike Onodugo. Ujaligwa Igwe of Umu Avolo Abo. Other traditional rulers, traditional ruler Igwe Linus Atugu, who is the Igwe of my own town, my marital home. The gentlemen of the press, lions and lionesses, ladies and gentlemen. I must call in a special way my chief medical director, who is seated here, Professor Obinna Onodugo. You're welcome, sir. I dedicate this lecture to the Almighty God, who has been my rock, my fortress, and my deliverer. In Psalm 18, verse 2, it is clearly written, the God who is our fortress, the God is my own personal fortress. To my beloved mother, Nemuroha Antonia Nwakego Ozioko, who nurtured me, my mom is seated here in spirit, nurtured my spirit, and to my late father, Chief Hyacinth Chukwunwike Ozioko Ohabenyi Asogwihe, the greatest Oxford, who saw in me the strength to thrive in a world that did not always believe in women, who didn't make it easy for women. To my beloved husband, Engineer Fabian Eze, and to my lovely children seated over there, Pascal, Chidiogo, Kenechukwu, and Ifunanya. Ifunanya is currently writing chemistry today in WAEC, so she's not here. Who patiently supported me all through my academic journey. My story is, you could see that the picture of my father is here. My father, my inspiration. My father's love. My story is that of story woven from the threads of a family unwavering support. My father's love, unwavering and profound, fuels my story and is a testament to the power of belief. My father gave me the tools to use in navigating the harsh realities of the post-Biafran War period, instilling in me a tenacity that will serve me well. My father and my mom became my first teachers. And so, there is this law or this circumstance, or in physiology, the Pavlovian law or the Pavlovian conditioning. When the dog hears the sound of the bell, the dog knows that it's time for food. And so, when I heard joy, and the answer is sir, joy, sir, that is my father calling me. You will know that it's time to bring my book, my class, my bag, my school bag, for review of my day's work, right from the primary school age. And so it became a routine for me. And then I lost myself in the service of others, only to find myself again in this chair, the professorial chair that we celebrate today. I shall explain in the next few minutes why this chair is so deserving. Let us go there. The eagle soared against the wind, pulling down the mountain and building the ladder, a lasting legacy. And there is joy climbing the mountain of lack of trained personnel, the mountain of lack of equipment, the mountain of uncoordinated research in respiratory medicine, the mountain of no voice to speak for the children who have respiratory diseases. And then at the beginning of the mountain, it seemed as if it's all right, we can get there. But in the middle of the mountain, Joy could see my teachers, my mentors, my friends, my colleagues telling me, move, you can do it. I stood there looking up, looking at the mountain, how big and how domineering it is. And I wondered if I could break the bounds. And then along the line, as I was moving, there was a need to build that ladder with which I will climb, as well as the ladder with which others that are coming after me will follow. And that forms the theme of today's lecture. We cannot understand what the mountains are and how the ladder helps to overcome the mountain unless we understand the respiratory system in children, what we should know. We need to know that children have peculiarities that are limited to their respiratory system. They are not half adults. Like some doctors would make prescription or will want to use equipment, and they will say, put half of it, half a meal, or give him 125 milligram of amoxicillin. No, sir. Children are not half adults and should not be treated with half medicines for the adults. Children, the peculiarities in children, they have preferential nose breathing, especially in infancy. That means that if the nose is blocked in a child, it could give serious respiratory distress. I got a call on one day, a doctor presenting in the emergency room, and she was telling me her daughter was not breathing fine. And she said she had stuffy nose. Immediately, I knew the reason why the child was not breathing fine, because the baby is in the infancy period and is a preferential nose breather. So once the nose is blocked, they won't breathe well. Children have large tongues in relation to the mouth. So if a child comes in unconscious, the tongue is capable of blocking the airway. So whatever treatment you are giving and you have not taken care of the tongue, it means that it's possible that you will not be getting the appropriate response. The larynx is high in position and more anterior. So in the event of intubation, endotracheal intubation, you need to measure properly as well as insert, knowing that the larynx is more anterior. So you need to navigate very well. They have highly compliant chest. In that case, they're easily vulnerable to airway obstruction. Anything that obstructs the airway, the thoracic cage will give in. And then they have low oxygen reserve. So if they are denied of air for a prolonged period of time, they will easily go into respiratory failure. So we need to note all this. I need you to hold this, please, when I need it. We need to note all this when we are handling the children. The burden of respiratory diseases globally is quite high, particularly in low and middle income countries. At the time I got tired of, when I'm reading, the next thing is asthma is affecting 340 million, more than 340 million people worldwide, particularly in low and middle income countries. 90% of deaths, low and middle income country. 60% not having good housing, low and middle income country. What is wrong with the low and middle income country? Can't we get it right? Acute lower respiratory infections are associated with morbidity and mortality. Particularly respiratory syncytial virus remains an important cause of early lung damage, which transcends into adulthood. Remember that a child may have up to 6 to 8 episodes of acute respiratory infection in infancy, and each episode causes significant lung injury. So we need to bear that in mind. In our low and middle income countries, we need to also be able to do the profiling for respiratory syncytial virus. Currently, part of the management is a prophylactic therapy, the monoclonal antibodies, as well as maternal vaccination. If we are able to define the burden, we will be able to join in the worldwide recommended treatment and prophylactic prevention. Tuberculosis remains the second most common cause of chronic respiratory infection after COVID. TB often coexists with HIV and remains a significant cause of death in children. In the last 3 months, we have had infants with TB. We know that at a time we didn't have malnutrition again, But after some time, it's as if malnutrition has resurfaced. So in our wards now, we have a lot of children coming in with TB. We have had like 3 or 4 in the last 2 months. The latest is a baby who found out in a very precarious circumstance. This baby and the mother found themselves living in an uncompleted building. And when I asked the mother, where do you live? She said, somewhere. I said, where? She said, uncompleted building. This baby came with all sorts of infection, severe fungal infection, including, and then also had tuberculosis. Now we have initiated treatment. But the problem with TB is that TB presents with poorly defined symptoms. So you might just see this baby losing weight, not even coughing, may just be losing weight. The only link or a kind of a lead may be that there is an adult that is coughing in the home, or that this baby has been subjected to adverse environmental conditions. Air pollution. Asthma remains the most common cause of chronic respiratory disease in children and adolescents. And air pollution is a major cause of chronic lung disease. Evidence abounds of air pollution-related deaths in parts of the world. Currently, air pollution causes more than 9 million deaths out of the deaths related to environmental sources. So in our study, in checking the clinical profile and risk factors in patients admitted with acute respiratory infection, Chinawa et al. In this study published in the Current Respiratory Medicine Review in 2020 found out that the major causes of admission in these children who present with respiratory infection are pneumonia and bronchiolitis. Majority of them had severe diseases, and the risk factors included age less than 1 year, type of acute respiratory infection, presence of comorbidity, lack of vaccination, especially measles vaccination or vitamin A supplementation, and exposure to wood smoke. We must note the important contribution of exposures to respiratory infection. We will demonstrate that in the subsequent slides in our lecture. But please let us not belittle exposure to smoke. Some parents who smoke will say, oh, I smoke outside. My children do not know I smoke before I get home. Remember that the particles that come from the smoke could be deposited on your dress, on your clothes, and even in your nails. So your children are exposed to secondhand smoke, and this will predispose them to respiratory infections. And then we are not able to demonstrate the contribution of respiratory syncytial virus in our environment, probably because we have not taken it very seriously to look for them in viral studies. But this cohort study done in South Africa, McCready et al. Reported that respiratory syncytial virus was an important cause of lower respiratory infections and altered lung function in their cohort. The risk factors included preterm birth, low birth weight, female sex, less wealthy household, and then the maternal risk factors included maternal allergy, maternal smoking, and HIV infection. What about the chronic respiratory diseases? What are the risk factors? Globalization and urbanization. Many people are leaving the villages that are migrating to the urban areas. There is overcrowding, there is congestion, there is pollution. I pass my neighbor generator. You have your own and I have my own. And then other sources of pollution, burning, bush burning, use of unclean cook stove. A lot of people are cooking with charcoal, especially down that the economic downtown is hitting everybody. People who cook with charcoal stove, people cook with other unclean stove. Even the LPGs that we use, they are, yes, clean energy, but there are some of them that will still give you air pollution if not taken care of. Tobacco use, indoor exposures and outdoor exposures, allergens, and then impaired pulmonary function, allergic sensitization, and chronic respiratory disease. But when we define the burden, we need to also look at what are the barriers to achieving optimal respiratory health. For those of us who are doing the interventions, why is it that our patients do not respond when we treat them? The high respiratory disease burden can be explained by biological characteristics as well as environmental factors. The determinants of adverse outcome include ancestry. And so in many studies you will see mortality is higher in black people. Why is mortality high in black people? It's also associated with environmental exposure and access to care and cost of medication. So, some of our studies focus on access to care and cost of medicines, and then poverty, and then lack of education. Currently, over 60% of the population in sub-Saharan Africa are living below $2 per day. How is it possible that somebody would survive all these diseases on $2 a day? And then Bush et al. Looked at the social determinants of lung health originating from birth and persisting across the life course. It is worrisome to note that any damage, lung damage, that happens in early infancy could transcend to chronic lung disease as adults. So those who are suffering from chronic obstructive respiratory diseases and chronic bronchitis or asthma and all sorts may be linked to exposures they had in early infancy. And that is very well buttressed and highlighted in this study, that passive tobacco smoke, indoor air pollution, lack of access to even the simplest affordable medication are the causes of prolonged lung injury and lung disease that will transcend to poor lung health as adults. We must note the gross disparity in outcomes within and between countries, particularly in resource-poor settings. The poverty, the lack of resources, the poor access to trained personnel, and poor access to well-coordinated care is the bane of lung health, both in children and adults. So how can we reduce the burden of respiratory disease in Nigeria? The history of and practice of pulmonology in Nigeria. Before the 1950s, there was no specialized pulmonology service. Pulmonology was seen as part of the general medicine care. But beyond 1950s, a lot of scholars came together, tried to improve pulmonology service and establish dedicated pulmonology services in their various centers. And children and adults with respiratory diseases are now cared for by pulmonologists and not just the general physicians. Recent breakthroughs in the institution-based capacity building through training, development, equipment availability, and international collaboration in advancing interventional procedures have made a very important landmark in improving the care for children and adults with respiratory disease. Who are the key players? The key individual and researchers who played substantive role in development of respiratory medicine practice in Nigeria included Professor B.O. Onadeko. Professor Babatunde Onadeko did an extensive work in chronic obstructive pulmonary disease and also looked at the clinical profile, the characteristics and in the regions and even locally, defining what specific characteristics that are prevalent in Nigeria and neighboring countries. Professor E.O. Bandele also did an extensive work in asthma, defining asthma profile, asthma characteristic, epidemiology, treatment, including inhaler therapy, lung function, and all that. And then Prof. Gregory Erabo, I can't name all those. These are adult physicians. But when it comes to pediatricians, Professor Wilson Aderele, Professor Osa Oviawe, Professor Abdul Wahab Johnson, Professor Adogoke Falade, our own Professor Tabo Ogono, Professor Wilson Osarigiabo, and so many of them, they have really toiled to improve the practice of respiratory medicine in Nigeria. What about UNTH? Poor awareness, despite the huge burden of respiratory disease, still exists and is a major setback to our practice. I once saw a mother in the clinic, and after reviewing the child, I told the mother that this might likely be an asthma. Back to sender, and she took her child away, even when I was begging her to please come back for a proper assessment. Poor access to medicines. Doctors are engrossed in the old practice, even currently. I know when you enter the general practice, many people still give oral salbutamol, oral aminophylline, and all that. Please note that these are no longer acceptable. They are not in the current guidelines for management of respiratory diseases, including asthma and COPD. Prior to 2002, there was no service point for follow-up for these children. So it took the initiative and the ingenuity and the belief and perseverance of Professor Tabo Ogono, who initiated the establishment of the first asthma clinic in UNTH with the support of the big pharma, the GSK, coming in our aid. Even at that, we didn't have anything. Even the inhalers we didn't have, the nebulizers we didn't have, the peak flow meters we didn't have, and the inhalers we didn't have them. So the GSK came to our aid and provided the basic things we needed. You will see in the next slide what we were able to get and what we used. And then it was a reminiscence of my father's call, joy, and the follow-up answer, sir, when Professor Gon will always call Eze. And once he says Eze, I know that there's a problem. And the next thing he will say, Eze, I need inhaler. And I said, sir, we don't have anyone. Didn't patient come with his own? He said, that one is your wahala. Give me inhaler. So we will source this inhaler ourselves. At a time, we began to keep free inhalers in the clinic for those children who will come without their inhalers. And even those who will come with asthma exacerbation without even knowing they have it. So we kept inhalers in the clinic. And each time he didn't see anyone, he would say, Joy, Eze, where are the inhalers? And I would like, sir, we don't have any. Say, I need inhaler. So you must provide the inhaler. Sometimes it took me driving from the UNTH new site to the old site to look for the inhaler, the nebules, especially the ipratropium nebules. These were not regularly available. Remember, the management at that time was oral salbutamol and theophylline, aminophylline, and doctors were quick to inject into a child an aminophylline injection. One of my patient's mothers slumped and died because she had aminophylline injection that was given rapidly. Aminophylline is not supposed to be given boluses. Even if you have to use it, it's in life-threatening situations. So we need to unlearn this practice. And then Professor Tabo Ogono went ahead to establish what is currently known as the respiratory clinic. Our own Professor Adeza Ayuk and myself, we had to push harder to sustain our patients, going further to look for special devices for these patients. And so when we get to conferences, instead of carrying new shoes and new clothes for our children, we would rather buy the special devices and buy all those nebulizers to support our clinic. Improving clinical outcome. So these are some of the special devices that we have. The bigger one was given, were supplied by the GSK pharma to us. And then at a time when we exhausted the inhaler, the special devices, we had to fashion some kind of an improvised inhaler. So we will have all this in our clinic. We'll nicely cut it and make it, seal it up so that it does not injure the child. And we teach the patients routinely how to do this in their homes. And so the inhaler will be plugged in on this end into this, while the baby's face, this one is on the baby's face. And it's as good as having the spacer devices. I walked into a shop one day and I wanted to buy the spacers for the patients. And they told me one is 6,000 naira. That was as far back as 2003 or 4 or so. So how would a patient pay 6,000 naira for a plastic like this? So we decided that we will help our patients. And that is part of surmounting the mountains created by service. So in our experience, these are the cases we saw. This was a 15-year-old with intrathoracic mass, left pleural effusion. The intra-abdominal extension are also shown on the chest CT. Incidentally, this child had gone to every place looking for cure. The pleural effusion will readily recall because the cause, which is the intrathoracic mass, had not been taken care of. We did a lymph node biopsy, and it showed high-grade lymphoma. Unfortunately, the cost of care and the cost of staying in the hospital made this patient to sign against medical advice. It was so painful to us that we could not continue keeping the child. This case was a case of a 15-year-old, again, who was trying to sew something and put the pin in her mouth. And the next thing, the pin ended into her lungs. So I don't know if you could see very well. There is this, sorry. If you look around here, I'm not sure it's showing, there is a pin. See one slender thing. This is office pin in her lungs. So we had to, first of all, treat the chest infection she came with before we involved the surgeons who eventually did a thoracotomy, trying to look for the pin. Eventually, she had some kind of a segmental lobectomy in the area of that pin. And this is a 10-year-old, again, with bronchogenic cyst. Bronchogenic cyst is one of the congenital intrapulmonary masses. This is a 10-year-old who presented with bronchogenic cyst with recurrent effusion, which we also had to manage in conjunction with Professor, the surgeon, the cardiothoracic surgeon, Ezemba. We had to manage with Professor Ezemba's unit. The surgery was done and the mass was eventually removed. And then the next one is a 2-year-old female admitted into the PICU, pediatric intensive unit, with evidence of upper airway obstruction. He had a prolonged intubation even while on admission, and now presents with post-intubation stridor after 3 months plus stay in PICU, and still having episodes of desaturation. So this kind of patient will require something like a tracheostomy or a laryngeal reconstruction to expand this area that is constricted. And that also shows the importance of a multidisciplinary team management in respiratory diseases. And this is an 8-week-old baby that we received at just 1 week old that was choking with feet, and we had to investigate. This was a case of suspected tracheoesophageal fistula. We did the ENT unit, Professor Zanole is here. We had an MDT meeting, and he went in to do rigid bronchoscopy, finding something that looks like a laryngeal cleft, but we needed to define it further. And then we lacked the flexible bronchoscope, which we would have taken down to explore the respiratory system. And at the end of the day, the child relation had to take the child to Lagos, where they got the flexible bronchoscopy, and the child is doing well now, currently carrying his school bag to school. My journey to the heights. What defined my journey to the heights? I had to do a personal development in terms of gathering clinical skills, as well as engaging in research. And then that brings again my initiation, or the initial journey I made climbing the mountain and trying to build up this ladder. You can find me at the foot of this mountain, look with my knapsack ready to climb, smiling, thinking that it's easy, until we went along. I was engaging in advocacy, leadership, and mentorship in our research network, as well as going for clinical specialization. I have an MPhil degree, Master of Philosophy degree in Pediatric Pulmonology at the University of Cape Town. Mingling with the great minds and ruling the world of respiratory medicine, you may not know what is happening in the world unless you mix up with the world. And so we took it out to mix up with experts in the field and those who know more, looking for collaboration in research, looking for collaboration to improve our clinical practice. And that's the attendance at the first Pan-African Thoracic Society Conference in Nairobi, Kenya. That's this one on my right-hand side. Professor Ayuk is sitting on the extreme right, while I am on the extreme left. We have always been in this journey together. And then the next one is the American Thoracic Society Conference. This one is the 2024 conference, but I started attending the American Thoracic Society Conference in 2019. And the other one is the Pan-African Thoracic Society Methods in Epidemiologic, Clinical and Operations Research, the MECOR program, where we do research work 1 week in every year as it comes around. Also, my participation in international and national conferences, the Pediatric Association of Nigeria Conference, Nigerian Thoracic Society Conference, and then the American Thoracic Society Conference, the International Society of Pediatric Pulmonology Diseases Conference. Because it's at this conference that you will learn what is the current management for these diseases, as well as look for collaborations, those who will collaborate in improving your own setup back home. Improving respiratory care in Nigeria, my early beginning. This was our lung ultrasound training in Nairobi in 2016. I'm wearing red standing behind while Professor Ayuk is holding the probe for the lung ultrasound. And we had to develop our skills in lung ultrasound. I enhanced my skill further by involving myself in the bronchoscopy sessions in the Nigerian Thoracic Society Conference, having a hands-on training at the conference. Also, going further to do the intercostal chest drainage. At the time, I became a very important customer at Artisan for the goats. So I will go and buy a full goat, and then we will cut the goat using the rib cage and the chest for intercostal chest drainage learning in UNTH. So sometimes you come into a training session and you see the goats. And then we were also buying the chickens for introducous access. So we'll buy the chicken and get the leg so that we can easily insert lines. So we did this repeatedly just to lay our... So when you say that we don't have mannequins, we don't have this, CMD should come and provide that. And then that limits your practice. I think you should come out and think out of the box of what will improve your practice without the mannequins. So we had to use the goats when we didn't have the mannequins in our wards. Improving the skills in respiratory procedures and interpretation. I had to also go further to learn spirometry, not just learning the procedure, but learning the interpretation. So I have the certification for spirometry procedure. This I did in Ibadan. I went on my own. Just I heard that there will be a spirometry training, and I had to enter the vehicle going to Ibadan to go and train. And they were all looking at me like a mole in their midst. It's not my business. I came here to learn, and we all learned together. So that's the sessions of spirometry. What about research? My first attempt in getting myself involved in research with others was in the PASMACOR program. That's the research program, joining the PASMACOR program, the initial level 1 program in 2018, and then did level 3 in 2021, acquiring the skill and competencies in research. Sonia Boost was the past president of the American Thoracic Society, who personally donated her funds. She said it's her children's foundation, $400,000 to advance research among upcoming respiratory specialists and young professionals. And then currently I lead the level 1 team in this. I co-lead the level 1 team with others in the past MACO. Defining the magnitude of the problem. You need research to be able to say that this is the problem. Sometimes data may be lacking in our setting, low and middle income countries and Nigeria. So we needed the data to be able to advocate. We started by defining the burden among people who thought that they were well. This was a study we did among university undergraduates, including the adolescents and young adults. And you can imagine that up to 25% of participants in this study had respiratory morbidity, abnormal spirometry. Yet, only 12.9% of them had a previous diagnosis for respiratory disease. That means somebody can actually be walking around without knowing that he has a respiratory condition. And now the famous anti-go-go-go. I found myself in the Nigerian prisons, the correctional center in Enugu. I thought we could just do this study among the adolescents, but by the time we found out that the adults may need the spirometry as well, we had to expand our study and resubmit for the protocol for approval to include the adults. And then when I arrive at the prisons, you know, when you are doing spirometry, you are telling the participant, to the person that is blowing it, keep going, go, 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 go. So once I arrive, they will say, hey, anti-go-go-go has come. We found high rate of respiratory symptoms among them. Up to 69% of them had respiratory, either it's coughing or sneezing or this or that. And then we had abnormal lung function in up to 45% of them. The problem is on the diagnosis of chronic respiratory diseases. There is no setup, like a formal setup for respiratory care among them. Not minding that some of that they are predisposed to, you know, correctional centers, sometimes overcrowding, sometimes exposure from others. There is need to promote lung health and enhance access among these underserved, vulnerable population. And then bridging the gaps in asthma care. What did we do? The asthma, we said, is the most common respiratory disease in children, and also an important one in adults, affecting more than 340 people, particularly low and middle income countries. Nearly half of the affected are children less than 15 years. And asthma in Nigeria, the prevalence is 4.8% currently, following the Chest Africa study, which is the PI is my mentor, Professor Obianuju Ozo, in the Lagos University Teaching Hospital and University of Lagos. She's an alumnus of this institution. So there is poor knowledge of the disease and lack of access to asthma diagnostics and lack of availability of inhalational therapy. So we need to, again, look at what we could do. We try to look at what we could do. This is a 2024 guideline for management of asthma in adults and adolescents. If you look very well, you will see that the step 1 for asthma maintenance therapy, outside having acute exacerbation that will need presentation in the emergency room, is the as needed low dose inhaled corticosteroid formoterol combination therapy. Inhaled corticosteroid is the bedrock of asthma management currently. If you are taking inhaler and you keep having repeated asthma exacerbation, you will need the inhaled corticosteroids. And then when you move to step 3, step 4, and even step 5, you will need, in addition to the inhaled corticosteroid formoterol combination, the anti-IgE, the omalizumabs and co, the interleukin receptor antagonists and all that. There is a track 1 and track 2, so you need to select which one that is will be good for your patient, or that is what you can assess. So we assess the knowledge among patients, physicians, and healthcare professionals. One of our studies that we did among Nigerian doctors in general practice and in family medicine practice, they lacked the knowledge of asthma broadly, and they lacked the knowledge of asthma management. In the same vein, their problem again was that we have the guidelines, but we do not have the medicines. So there's limited availability of asthma medicines. And then again, when they are even available, they are not affordable. So this study on availability, this is the one we did on their knowledge, which I have explained the findings on availability and on affordability, where we have the guidelines. And then they also requested for better access to diagnostics and medicines. So the National Survey of Asthma Availability, Asthma and COPD Medicine Availability and Affordability we surveyed 128 pharmacies, both private and public pharmacies, looking for this medicine. So we went physically to the pharmacies. We visited most pharmacies within 5 kilometers of each other, and then the finding was that asthma available medicines were oral corticosteroids and oral salbutamol, which were available in more than 70%. But definition by the WHO Health Action Initiative method is that medicines must be available in up to 80% of pharmacies surveyed for you to say that these are available. So inhalational corticosteroids were not available in any public or private hospital pharmacy in Nigeria. And none of the EML medicines were affordable. So less than 20% of Nigerian hospitals had inhaled corticosteroids in their pharmacy. And then the least number of days of wages. So we looked at how much it will cost somebody, an average Nigerian, earning the minimum wage then, 30,000. But even at now, 70,000, to afford one inhaled corticosteroid containing inhaler. And it will take him to work for 3.5 days, 3 days or more, to be able to buy one inhaler that he will use for 30 days. Again, the cost of inhalers were between $31 to $126. That will tell you that they were not affording it. In this picture, these were what we found in the hospitals, mainly oral drugs. And then we took it to the American Thoracic Society conference in 2019. Many came defining asthma pathology and all that. But Joy Eze came saying, guideline is there. Where is the medication? And they all looked at me and they got interested. It was like a mind-boggling thing. So we all have the guideline, especially the Global Initiative for Asthma Guideline. But where are the medication? We say we don't have them. And then many other countries took it up to actually survey whether they have those inhalers in their country. And this all contributed the data and the advocacy for review of access to inhaler treatment in the globe. And it was referenced in the Asthma Global Report of 2022. This was also an award-winning abstract where I won the Best in Show award at the conference, being the best abstract presented in that conference among international participants. This is an editorial we wrote on the World Lung Day, looking at improving access to devices and inhaler. We identified the problem, lack of strong will from the government and stakeholders. And then there's monopoly in the market. Then GSK and GES and AstraZeneca were the predominant big farmers that were handling these inhalers and all that. But at the time, GSK left Nigeria. AstraZeneca left again. And we were stuck. And by that time, inhalers, the salbutamol inhaler cost like 1,500. But subsequently, it went to 18,000, 11,000. Enter the market now and get the inhaler and think whether the average Nigerian can afford it. So we identified the problems. We said, please facilitate free or subsidize the cost of inhalers. Please, can we encourage the importation? And not just encouraging the importation, we need to build local factories. Our big farmers should help us to produce them locally here so that patients can afford them. Again, we need to reduce the administrative bottleneck, clearing in the wharf, all that. Come and register in the NAFDAC. We should have seamless registration processes, and we should have quality control to ensure that these medicines are adequate. We also identified other factors: unequal distribution, catastrophic costs. In our next slide, in our next study, we looked at asthma economic burden, And we found out that the management of asthma, presenting to the hospital admission, coming to the repeated hospital visits and all that, and even the missed school days, loss of productivity by parents and all that, was constituting a huge burden on the parents and families. The disability life adjusted years assesses like the number of years of life lost by not having a proper care for asthma, as well as the risk of death, the risk of dying from the disease, quantified in economic terms, and it was quite catastrophic for our patients. We looked at factors that influence asthma control, and we noted that asthma control can be influenced by the family size, family demographics, the environment, and then the comorbidities like allergy. Up to 41% in our cohort had comorbid allergic disease that also impacts on their quality of life. The large family size was said to be productive. Please, Joy Eze did not say go and multiply. God may have said go and multiply, but in terms of allergy, when you are multiplying, know that the inhaler techniques and the cost of care, the catastrophic cost, is a limiting factor, in as much as having larger children and a larger family may be protective. The psychological problems in asthma, we decided to look at whether these children who come to the hospitals every day, in and out of the hospital, are actually coping with the disease. And we found that some of them actually had symptoms of anxiety and depression. We also noted that parents were too overprotective. They did not allow the children to play with their colleagues. They will always say, no, don't go, you have asthma. No, don't join them. And the child will begin to feel inferior. Some of them identified that they were stigmatized, and their friends did not like to associate with them, especially when they bring out their inhalers to use in the public. And then we needed to also look at asthma care as a holistic care. We needed to work with the psychological medicine team to take care of these children. These were my participation in World Asthma Day, bringing in knowledge to the grassroots. We had visited several rural communities, Ubo in Ogude, and then in Obukpa and in Nsukka. And the next visit, I had promised my CMD that I will be visiting his village to teach about asthma care. Why do we measure exposures? Early life exposure is associated with low lung function. If you are able to follow this diagram, you will see that here, when a child is even intrauterine, there are exposures, like exposure to air pollutants, exposure to maternal smoking, and all other exposures. So those who have early life exposures will tend to have declining lung function beyond age 20. So somehow even before 30 years of age, you're already manifesting the symptoms of lung injury and lung disease due to exposures. And then some of you might remember when I was visiting your kitchens, mingling inside your kitchen. This instrument that looks like a bomb is my small device for measuring air pollutants. And then the other one that looks like a pen is the Lascar pen that measures carbon monoxide levels in your kitchen. So the outcome of this study is this, that those who used the charcoal, the wood, the crops residue had higher levels of kitchen exposures as well as personal exposure. Some of them in the previous pictures, you could see some of these, the participants wearing my instruments and their waist. So those who were exposed to these sources of cooking fuel had more, high levels in their homes. LPG seemed to be the cleaner gas, the cleaner source of fuel. But I noticed that those who have LPGs that were not burning properly also had high levels of particulate matter exposure. This is the air quality index in Nigeria as at yesterday. If you Google air quality index, you could see what it is in Enugu and in other places. Enugu is in red. I'm happy the Commissioner for Health is here. Please, we will need to also look at why the air quality index in Enugu is in red. What are the sources of pollution? Influencing global policy. So our research, both the asthma medicine availability research, the air quality measurements and all, contributed to the United Nations Declaration of improved or free access to inhalational medicines for those who have chronic respiratory diseases. This was done in December 2025. And just last week, the union, that's the International Union for Tuberculosis, also joined in calling for free access. No child or adult should die from any chronic respiratory disease because he doesn't have access to care or is not having access to inhaler. So my clinical specialization, again, surmounting the mountain, I decided to move to Cape Town, spent my 2 years there, my family staying behind and waiting for me to come, and my husband also patiently waiting while I advanced myself, learning all clinical procedures, advanced clinical procedure, including bronchoscopy, including multiple breath washout, and diffusion capacity for carbon monoxide, and even the sleep studies. And then this is a big project. It's a groundbreaking research in South Africa. Prior to my arrival, it was not known the burden of primary ciliary dyskinesia in South Africa. Some group have attempted to do the electron microscopy looking at the cilia. You know, I will show you the pictures of the cilia and defining those who may likely have PCDs. We had a German collaboration. This is Hermann Omran from the University of Münster. He flew in to train me on a cilia study. And this is the training ongoing. And then in this one, I hope this video will play. Our finding is that more than 20% of those we studied, both children and adults, because we started with children, and then adults who were always coughing, always running nose, not knowing what was wrong with them, were referred to us. So we included them, and we found PCD in about 3 of these adults. So the fact that you are an adult, you may note that what you are suffering from is something that is genetic, that came long ago. So this is the cilia. So when I take your cilia sample now, you might see that you have the cilia moving. That's the normal one. But the abnormal one is the look. You look me, I look you. It does not move anywhere. It's just immobilized. So abnormalities of ciliary function or ciliary dysfunction is the baseline characteristics of those with PCD. These were some of our patients in South Africa. You could see that of their lungs are completely destroyed, and these were confirmed PCD cases. One of them was a 29-year-old who didn't know what was wrong with him. In fact, he was already feeling stigmatized, always coughing, had halitosis, bringing out very purulent sputum. He was one of those we diagnosed PCD with, and that formed my dissertation. And this is my graduation field. And then we presented this abstract in the International Society of Pediatric Pulmonology, Pediatric Respiratory Disease Congress in Porto, Portugal in 2024. It was also an award-winning abstract, winning a prize of the Young Investigator Award. So active search for rare diseases. Some of the rare diseases, including the cystic fibrosis and all that, with us. In South Africa, we manage those from Cameroon, those from Ghana. So I know that Nigeria is not spared. Meanwhile, when I returned to Nigeria after training, what I saw was pre-print on PCD, query diagnosis, so and so presented somewhere in Nigeria, query PCD diagnosis. And it was in my mind, my vice chancellor, sir, I think it's high time we stopped publishing papers that are querying when we can do it. So we should be able to institute a PCD diagnostic center. I could lead that establishment. So the zebras, I was meant to spend one month of my salary to spend this child who presented with us, 10-week-old, with respiratory symptoms, respiratory in the respiratory sample. Pseudomonas organism and quite destructive to the lungs. You can imagine this 10-week-old having Pseudomonas in the lungs. And we thought this could be cystic fibrosis. So I contacted my trainers in South Africa, and then we tried to see if we could see the sample. So we couldn't go ahead. But when I traveled, I got the enzyme replacement, which cystic fibrosis is a problem with the channel that transfers salty fluid across membranes and the epithelial cells. So if the channel is faulty, those fluid will get sticky. So this child, we suspected had cystic fibrosis. By the time I came back, I brought the drugs, but the child had already died. This is the third of the children of that mother dying from the same symptom, sudden respiratory infection and severe respiratory disease. It was the third child. So it's also on me to look for mother. So that pushed me to join the Cystic Fibrosis Network, where we are now collaborating to see if we could set up diagnostics as well as treatment for those who have this kind of disease. Addressing the knowledge gaps in UNTH, we noted that to improve care in the children, we needed effective emergency medicine, effective pediatric intensive care, effective respiratory. And then thanks to our CMD, who initiated, supported the thoughts about training of pediatric personnel. With this, we identified the deficit room, including capacity and instrument, lack of equipment. And then that led to sending pediatricians to train. Initially, myself went for pulmonology, while Dr. Moore went for pediatric intensive care. But that has gotten stronger through the collaboration of the African Pediatric Fellowship for African Pediatric Fellowship for pulmonology, for pediatrics training. We collaborated with them to train many others further. So in this picture, you could see those that trained in the emergency care. Dr. Goilo trained in emergency. Professor Edelu trained in emergency as well. And then we trained the respiratory nurse who is working with us currently in the clinic. And then we had 2 physiotherapists, Ngozi Ekweme, training in PICU and all that. So we enhanced clinical practice in UNTH by building capacity for care of pediatric disease. We also enhanced clinical practice through equipment support. Our CMD supported the respiratory team by providing spirometers. But we also had opportunity of getting the team, both adult and pediatric, to also donate a full set of spirometer, in having all the equipment, all the accessories to it. And that's the picture the day it was presented to management. The return of emergency pediatric rigid bronchoscopy. Again, as CMD having a large heart, before now, some children who come with foreign body are somehow referred because our grasping forceps were too old and broken. So our CMD ordered, when he visited the emergency room, he saw that one child was there in his airway, and the team was trying to find a way to remove it. So while I was the CMAC, he actioned the purchase of a full set of 5 grasping forceps for removal of foreign body. As if we all know, weeks later, a child presented from Abakaliki with that, looks at the tip of the pen, and it was successfully removed. Thank you, CMD. Advancing research. I am part of the International Health Committee members in American Thoracic Society, as well as a MECO steering committee member, driving and advancing research in respiratory medicine, as well as instituting mentorship, strong functional mentorship. So these are some of the people in that committee. And then also I lead the level 1 research Pass Me Core program. And then I also graduated as the pioneer of the Women Leadership Training Program, and all in a bid to enhance lung health. If you look in that picture where we had our hands together, maybe you might be able to identify the one that is my hand. The other one is research and skills transfer. Some of my mentees are here. Nena, Dr. Nena Nweke, stand up, is sitting here. She is advancing her exposure research currently. She won the Pan-African Thoracic Society Lung Health Initiative Award, and see her bouncing in that picture, creating awareness of increasing optimal lung health. She's also leading our vaping and shisha smoking study. Mind you, our adolescents and teens have engaged in shisha smoking and in nicotine use. So when you see your child carrying a pen, please look at it and see whether it's an e-cigarette. So I had the opportunity of serving in the administration of our ebullient CMD, our pragmatic leader, as the chairman medical advisory committee and director of training. And I also tried to use that position to enhance training in relation to airway. So we instituted a basic life support training program for all staff. If anybody slumps in any part of UNTH, there must be somebody trained that is there. So these are, I've mentioned the international bodies I work with, and then these are the awards. Then the major part of it is 3 weeks ago, I stood before the participants of the American Thoracic Society with a handshake from the president, winning the Global Leader in Respiratory Health Research Award of 2026. I am the third female that is winning it, and the first African woman that is winning that award. In conclusion, my Vice Chancellor, sir, let the children breed, and let Nigeria breed, let the world breed. And God asked, whom shall I send? And who will go for us? And I said, here I am, Lord, send me. Putting down the mountains and building the ladder. Here I am, my CMD, send me. I need support to improve service in the hospital. And part of that support that we need is to advance interventional bronchoscopy. I sojourned to University of Düsseldorf, Germany, to participate in the course of interventional bronchoscopy, just in anticipation that we will have it in our center and in the University of Nigeria. My gratitude goes to the Vice Chancellor, Professor Simon Otuanya, who approved my inaugural lecture today, and to the university community, the Provost and the entire College of Medicine community, and the Chairman Senior Ceremonial Committee, my CMD and the entire UNTH community, and to Sonia Booth and the entire ATS family, my mentors and my supervisors, the chairman and members of the inaugural committee, led by our own action et al., Professor Chinawa, who is also here. And then, in a special way, I thank all my trainers who are here. My supervisor, Professor Bid Ibe, supervised my Part 2 project with Professor Ojinaka, Ngozi Ojinaka, they are here, and then Professor Tabo Ogono. They made sure that I crossed every T's and I dotted every I's, and my Part 2 was very seamless. I also thank those that supervised my MSc project and my Master of Public Health work. I convey my gratitude to them. And then to my family, I thank my children who have been very patient. The story of my doing residency and having children at the same time is for another day. But my children have been quite supportive. Childbearing actually brings blessings. I passed part primaries when I had Chidiogo. I had Chidiogo 3 weeks after I carried my big stomach to Ibadan. I also had Kenechukwu during part 1. It was also a big stomach. I had Kenechukwu 4 weeks later. And then Ifunanya is the last one. She's taking WAEC today, chemistry. My son Pascal is an engineer who graduated with honors. And then to my immediate family, I must remember my dad, Ohabenyi Asogwihe, Chief Hyacinth Ozioko, who initiated my excellence in academics by tutoring me from primary school. The joy, sir, I have never forgotten. Yielded fruits. And my mom is here. Mama, say hello. My mom, Nemroha Antonia Wakego Ozioko, Ojene Nwayo, Onye Nudia, Oga Deregemma. Mama, thank you. And to my siblings, I thank you always. My sister, Mrs. Josephine Ovaga, became my second mother. In fact, when I'm on call and I'm not able to take care of the children, she comes to the house and picks them. And then I will pick them up when I come back. Thank you so much. And then the Reverend Sister who supported me in prayer with her circle of Sisters of the Immaculate Heart of Mary. And then my extended family, Unde Amokwa, Unde Amadim, entire Nru community, and entire Ihenewere community. Ekelemu no, my Vice Chancellor, sir, permit me to talk to them in the language they will understand. Une meo, unu lakonu unu zori korodo lagde na aye erugwe lugwabo. Aye erugwe lugwabo. Thank you so much for your support. My husband's family, I say thank you. You received me so much. Ikorodo Dejen, Alwan, husband, my loving husband. You know they say the place of a woman is in the kitchen. The place of a woman is some say is in the Zoza room, and some say is in the kitchen. So this man here never believed that the place of a woman is only in the kitchen or in the Zoza room. And that he encouraged me right from the beginning. Thank you so much, my darling. Ime, thank you. And to my colleagues in the department, thank you so much for your support. You have all been there for me. And though we have been toiling, but it has not been easy. But we were able to surmount the mountains. So in conclusion, my climbing this mountain and reaching the peak suggests that many of us can actually climb the mountain. I've climbed, I've reached the peak, and I left the ladder there for those coming after me. And to God be the glory. To all those that are present here today, I thank you. And then my teacher, my primary school teacher is here. She celebrated her 80 years old last year. Email. Thank you so much. Thank you. And my nanny, Mama Nneka, and my daughter, I took her when she was 9 years old, and she lived with me till she got married. They are here. Thank you so much. These are people who took care of my children. Thank you so much. Kedu ihe ngenye gị Chineke ọmamma mma zuru arụ? Kedu ihe ngenye gị Chineke odogwu n'agha isi mụ? Ọ bụ onye ga-akọ mmeso ọma Chineke? Naanị abụ ọma ka m jiri bịa n'iru gị Chineke. Abụ otito ka m jiri bịa ezi Chukwu. Soro mụ na-eto ya ọ dị mma. Soro mụ tobe ya ọ dị mma. Ndị nke Chineke bịa, aga m akọ ihe Chukwu mere m. Ịhụnanya Chineke karịsịa. Soro m too Chukwu mgbe niile ka ị zara m. Ị na-aza m elele anya n'azụ. Mgbe nsogbu ka mbe kuru gị, ọkwa ị zara m. Chineke onye dị ka gị ezigwe. Abụ otito ka m ga-eji wee kene gị Chukwu nna m. Abụ otito ka m ga-eji jaa gị mma. Chineke
standing ovation and a round of applause. Can we give it all up for the 242nd inaugural lecture of the University of Nigeria? Dalunu. The celebration will continue after this, please. Please, let's be seated. Can we please settle down? Can we please settle down? Ubuaja, Dalu. You have time for that. Thank you. That was a wonderful lecture, right? Did we enjoy it? Can we please put our hands together one more time for her? Quickly, before I hand the microphone over to the chairman for the post-chairman's comments, I'd like to recognize the 14th Vice-Chancellor of this great citadel of learning, Professor Benjamin Chukwuma Ozumba, who graced us with his presence during the lecture. I also like to appreciate the Nkiru cultural dance group. Please put your hands together for them. They are over there in their colorful attire. The Commissioner of Health, Enugu State, is here as usual. Ladies and gentlemen, please put your hands together for Professor George Ugu. I was told that 2 family members were streaming online, and I'd like to recognize them. Reverend Father Dr. Charles Ndukwe Ozioko, the immediate younger brother of the inaugural lecturer. Please, can we put our hands together for him? And Monsignor Anthony Eze, a brother-in-law. They all were streaming online, or they are still streaming online. Please appreciate them very specially. And to you, our distinguished guests, always making this particular inaugural lecture, or all our inaugural lectures, colorful. Please put your hands together for yourselves. And I think that College of Medicine are very partial. When it's one of them, they all come out in their numbers. And when it's another department or faculty, you won't see them. But I hope we will change and turn a new leaf. On that note, permit me to hand the microphone over to the chairman for the post-lecture comments. Please put your hands together for the chairman.
Thank you very much. Let me start by saying that it has been a wonderful lecture. And I want to also thank God for her life. I want to particularly say on behalf of the Vice Chancellor that we are particularly proud of you. Thank you very much. Yeah. She has won several awards. She has made the university proud. And she also appreciates her mentors. She appreciates in a special way the CMD, my friend, Professor Obinna Onadugo, and others who impacted so much as far as her life is concerned. The children must live. The children must breed. And there will be generational continuity. And the way to do it is by taking care of things pertaining to how children breed, respiratory diseases, respiratory sudden deaths and all that. So they must be curtailed. So I don't want to belabor you with so much talk. Today has been so wonderful. And I also want to say that the College of Medicine has done so well. I don't want to, I'm not so much, I'm not, yes, so they have done so well. I don't want to say I'm a superstitious person, but I want to believe that since I became the Deputy Vice Chancellor, University of Nigeria, Enugu campus, I don't think under any other Deputy Vice Chancellor we've had the number of inaugural lecturers since I came on board. So I'm very proud of College of Medicine, and I love you people so much for making me proud as a person for doing this during my tenure. And I have looked at the numbers that will come in the recent months and the near future, sorry. And I've seen so many people lined up, ESOM and others. They're all coming to do that. And so thank you very much, College of Medicine, and thank you very much, the inaugural lecturer. Thank you for making yourself proud. Thank you for making your family proud. Thank you for making College of Medicine proud. And thank you for making University of Nigeria and Nigeria as a country very, very proud. On that note, I now call on you to come forward and receive your certificate. On behalf of University of Nigeria, be it known that Professor Joy Nkiru of the Department of Pediatrics delivered the 242nd inaugural lecture of the University of Nigeria, titled Pediatric Respiratory Care in Nigeria, Pulling Down the Mountain and Building the Ladder, on the 11th day of June 2026. Congratulations. Signed by Professor Simon Uchenna Otuano, Vice Chancellor, and Professor Uzioma Onuzilike, Chairman, Senate Ceremonials Committee. Congratulations. Okay, come and join her. So you snap with her. Have you handed it over to her? Hand over to him. Hand over to him. Okay. So please snap them as she's doing the. Yeah, on behalf of the university too, we hand this plaque to you. University of Nigeria Inaugural Lecture Series, Professor Eze Joy Nkiru, 242nd Inaugural Lecturer, giving this day, Thursday, 11 June, 2026. Congratulations. Yeah, this is a bit heavy, but I'm a man, so we can carry any. So we know that your inaugural lecture, copies of this inaugural lecture could be given or handed over to your relations, your friends, your well-wishers, who may not be physically present or might not have been physically present here today. So the university is giving these copies as a token of gift, which you can also gift out. Thank you very much, and congratulations. I think there are some announcements to be made, after which I will declare the ceremony closed. Please, our golden voice, go ahead.
Thank you very much, my boss. While also waiting for the announcement of where we'll be getting refreshments today, I'd like to hand the microphone over to the Chairman, Senate Ceremonials, for vote of thanks and other announcements.
Thank you very much. On behalf of the Chairman, Senate Ceremonial Committee, I thank the Vice Chancellor, especially for allowing us all gather here today to enjoy Professor Eze's lecture. It goes down the the same way, very beautiful lectures we've had here from the College of Medicine. I join my voice with all those who've said earlier that the College of Medicine is powering very well. Thank you very much. Okay, in our lecture series, we will have our next on 18th of June, 2026. That is next week, Thursday. It will happen at PAA, University of Nigeria, Nsukka campus. When we gather, we will have Professor Thaddeus Chidi Zadibe talk to us. His topic is dealing with waste, expounding the geographies of garbage in African cities through the lens of the Sustainable Development Goals. Incidentally, he isn't here with us today. He has an NUC assignment somewhere. He would have been doing the closing prayers. But I implore everyone to make it a date with the Senate Ceremonials Committee on the 18th of June. Our ship will set sail and return to Enugu campus on the 25th of June. We'll gather here to have our 244th lecture by Professor Emmanuel Anayochukwesom of the Department of Inadvertent Breach of Nature's Best Neural Defense. If you've enjoyed today's lecture, thank you very much for coming, and hope to see you on these two occasions that we've mentioned. As you depart, I pray God takes you home and you meet your loved ones in good peace. Thank you very much.
Thank you very much, Mr. Chairman. I want to also lend my voice to say thank you to the music department for making this event a wonderful one. And to every one of you here, we'll say thank you. While we are still waiting for the announcement of the refreshment, I would like to hand the microphone over to the chairman to officially declare this event, get us the announcement for entertainment. Thank you.
Yeah, I think my assignment is coming to an end. So let me thank everybody who came here today. Let me thank in a special way the Vice Chancellor I love so much, Professor Benjamin Uzumba. He knows I love him and he loves me so much. You're welcome, sir, once again. And let me thank all of you for being here today, the inaugural lecturer for making us proud, and all my inaugural lecturers, my colleagues, inaugural, like my brothers and sisters, inaugural lecturer, or my brother, how do you pronounce it? Anyhow, as one of them, it's an elite club in University of Nigeria. Yes, to be an inaugural lecturer. I was the 115th inaugural lecturer of this great event. So I thank you all for coming. I'm very proud of all of us. The clergy, all of you, I don't know where to start and when to end. I'm just excited and I'm just very happy with the inaugural lecture and the inaugural lecturer. So on behalf of the Vice Chancellor of our great university, Professor Simon Uchenna Otuanya, I declare this inaugural lecture closed. Thank you very much.
All right, ladies and gentlemen, can we please be upstanding as we take the last stanza of the national anthem, followed by "To God Be the Glory," the last stanza.
O God of all creation, grant this our one request. Help us to build a nation where no man is complete. And so with peace and plenty, Nigeria may be blessed. things he has taught us, great things he has done, and great are rejoicing through Jesus the Son. But pure and higher and greater will be our wonder. Praise the Lord, praise the Lord, let the earth hear his voice. Praise the Lord, praise the Lord, let the people rejoice. Oh, come to the Father through Jesus the Son, and give him the glory. Great things he has done.
Thank you very much. Please, while we maintain our standing position, allow the members of the high table to recess first. We'll maintain our standing position and allow the members of the high table to leave the hall first. Thank you very much for making the 242nd inaugural lecture a very colorful one. Past inaugural lecturers and principal officers, your refreshments will take place at the Deputy Vice Chancellor's office. Distinguished academics, please, you just march down to University Main Hall. Our invited guests, there is a hall in Chapel of Redemption. That's where you'll be entertained. Those from Nsukka, please, behind the Chapel of Redemption, the hall behind the Chapel of Redemption, that's where you'll be entertained. I want to say thank you very much for coming, and God bless you. We wish those of you who traveled from far and wide safety as you return back to your destinations. God bless you.
Tobechuku, 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 he has done it for me. Tobechuku, 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 he has done it for me. Even before I prayed, Jehovah Nissi answered me.
Tobechuku, he has done it for me.
I said, even before I prayed, Jehovah Nissi answered me.
Tobechuku, he has done it for me.
When I was worried and couldn't sleep, he was walking behind the scene. Oh,
Tobechuku, he has done it for me.
Take it on one more time. When I was worried and couldn't sleep, he was walking behind the scene. Oh,
Tobechuku, he has done it for me.
Come and join me, worship him.
Tobechuku,
I said Tobechuku,
Tobechuku,
I said Tobechuku,
Tobechuku, he has done
I
it for
said come
me.
and join me, worship him.
Tobechuku, 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 he has
I
done
say
it for
come
me.
and join me, worship
Tobechuku, Tobechuku,
I say
Tobechuku, he has done
I
it
say
for
come
me.
and join me, lift him high.
Tobechuku, Tobe.
Behind the scene, oh.
Tobechuku. Tobechuku, he has done it for me.
Come and join me, worship him.
Tobechuku, 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 he has done
I
it
say
for
come
me.
and join me, worship him.
Tobechuku, He has done it for me.
Come and join me, worship Him.
He has done it for me.
Never see this guy got before you.
Wonder.
Hey, I never see this guy got before you.
Wonder.
I never see you, I never see you.
Wonder.
Hey, I never see this guy got before you.
Wonder.
I never see you, I never see you.
Wonder.
I say, I never see this guy got before you.
Wonder.
I never see this guy got before you. Hey, come on, who say? I say this God now. Wow. This God. I say this God. I say this God. I say this God. I say this God. Hey, I never see this guy got before you.
Wonder.
Yeah, I never. I never see this guy got before you.
Wonder.
I never see you, I never see you.
Wonder.
One, two, three, go. Everyone I felt. Hey, everyone I felt. Hey, everyone I felt. Hey, everyone I felt. One more time.